Is my screen is fully completely visible?
Yes, yes.
Yeah. Thank you so much. Okay. Again, a great welcome to everyone. So, before starting up with the session, I would like to take through you all about quick introduction about the skills for Med. So, all our Friday webinars are supported by Healthcare Sector Skill Council (HSSC). So we have been established in the year 2018 and we have been committed to providing comprehensive training program designed to enhance the capabilities of nursing professionals. We have so far 10,000 plus nurses have upskilled through our programs and 25 plus courses have launched and 35 plus hospitals have enrolled with us. And also about our Skills for Med learning pyramid. So what is this about? It is kind of a ladder for the nurses to achieve the leadership level. So it starts from stage 1. So stage 1 talks about the service excellence skills. That is, for example, I would like to give you a few examples of the programs what we do here. It is about the professionalism, communication, and about the etiquette. And next level, you'll be going on with the stage 2. It's about core patient care skills. And that is about basic nursing procedures and about the nursing care documentation, etc. and etc. So after the stage 2, you'll be converting as a clinical expert. And now next it will be like about your specialization skills in stage 3. For example, critical care course, or about infection control nurse course program, and also about emergency nurse course and labor room nursing course. For example, it's all the courses which is covered in the stage 3, where you'll become so deep rooted into the specialization where you are. And stage 4, it is here now about the leadership skills. You are going to decide here whether you're going to take up a role of nursing leadership or into the nursing management. Nursing leadership, it's about the vertical ladder where you will be growing up to the level of CNO, where the nursing management, it's about the horizontal pathway where you yourself gonna to look into yourself into the operations and also as the CEO of the hospital. So this is about our skills for med learning pyramid. And this is again an announcement related to the infection control nurse course program, which is a self-paced learning course which is collaborated with CAUTI. Probably we are presenting at, and this is the cost which is running right now with the offer price of 17,700 inclusive of GST. The course highlights are so comprehensive, and most of the nurses after undergoing this course have themselves seen the career transition as an infection control nurse, not just as at the bedside. And to know more details about our courses, you can contact, and you can see the number in the display. She is Ms. Jayanti, our admin manager, and you also can visit our website, which is www.skillsformed.com. So here comes the first speaker. So I'm so proud to announce Dr. Parivalvan Rajavelu, who is a consultant surgeon of Sundaram Medical Foundation, and he is our founder of Skills for Med. And he is emerged powerful advocate for nursing empowerment in India. He's not only committed to uplift the nurses and also equally is building systems to uplift the nurses into leadership roles through various structured programs and through his great mentorship and a bold forward-looking vision 2047 for the nurses. And nationally, he is recognized for all his contributions, and Dr. Pari is a national faculty for CAUTI and has played a key role in shaping and delivering CAUTI certification courses in healthcare quality, medication safety, infection control, and also into the clinical audit systems. These initiatives have impacted healthcare professionals across the country. His leadership extends to pioneering initiatives like CAUTI EndoSafe, a national audit-based program that works to enhance endoscopy safety in healthcare centers across India. He also serves as a principal investigator for India's national research on patient-reported experience measures in short its PREMS for endoscopy, bringing patient-centered for forefront of surgical practice. So Dr. Parivalvan, he's a unique blend of clinical skill, academics, And also system level thinking makes him an inspiration and a change maker for today's healthcare no landscape. Welcome you, sir. Will you take some other? So,
Dr. Pari, you're on mute, I believe.
so you can unmute yourself, sir. Yeah.
Screen is okay?
Yeah, yes, sir.
Okay, and the spotlight button. No.
So you will be able to hear all the introductions part, sir.
Yeah, I was able to hear.
That's great, sir. Thank you.
Okay. All right, good afternoon, everyone. Sorry. So I think this particular webinar series is very exciting for me because it deals with 5 topics about infection control, which are very, very important. And I really want to thank 𝐏𝐬𝐧𝐭 for their support for these 5 webinars. And this particular session, we are talking about recognizing the burden of HIA and how bundles help to prevent them. Understand the key elements of the 4 bundles like CLABSI, CAUTI, WAP, and SSI. Share success stories, challenges, and drivers for successful nurse-led implementation. So I'm only going to set the stage, and I'm not going to dive deep into this topic. So basically, I'll just set the stage, talk a little bit about the importance of bundles, and then I'll hand over to Mr. Vinod, who is the person at the front lines, and he will share his story and his experience about this bundle-based care. So that's the agenda for today. All of us are aware that HAIs are a preventable patient safety problem. So it is actually not seen. No, we don't actually perceive it, but it is like a silent pandemic in our own hospitals. If you look at the data that WHO and CDC are putting out, you can see that there's so much of morbidity and deaths happening that you can actually call it a pandemic. And these cause a lot of problems, but the main thing about this is that they are preventable. And in India, we have a long way to go to prevent these things happening in our hospital. So let's look at the global and Indian context. So in the WHO report on HAIs, they are particularly highlighting the LMIC, that is the low and middle income group countries, that 15 in 100 patients will occur in HAI. So if you admit 100 patients in the hospital, 15 of them will end up with one of the healthcare associated infections. And there is a study by in one of the Indian journals which actually almost mirrors this, and they were talking about 10 to 20% of the patients who are admitted or affected by HAI. Now, in the whole hospital, the ICU is the hotspot. If you look at CLABSI and ventilated associated events, they are actually almost double, ranging from 16 to 40% per 1,000 ventilated days. So this is what is happening at present in our hospitals. And this unfortunately, increases the cost and the length of stay in our hospitals. Okay, so that is what the problem is. And for the patient, it is a dual burden. One is the suffering, okay, the morbidity and mortality that happens. They have to stay in the hospital for a long period of time, and sometimes they end up with a long-term disability because of these infections. And more importantly, because even as of today, a very small minority actually have insurance in our country. Most people are paying out of the pocket, and these healthcare associated infections are doubling the treatment costs. And many families are becoming bankrupt. And there was again the study which showed a very actually conservative estimate of 87,000 rupees for an ICU infection. That was because no, they had done a mean for both public and private hospitals. But you can imagine if they go to a private hospital, it can be in lakhs. So that is how the economic impact is.
Doctor,
Sorry to interrupt. Yeah.
Yeah.
there's some black patches on this slides.
Uh-huh.
Okay, so some of the content is not fully shown.
Let me close all the presentations. 1 minute. Stella, can you stop presenting? Sorry for this. Let's sort it out. Have you stopped presenting? Listen. Just 1 minute. It's not on. No. It's not taking. Yeah. Still there, no? Why didn't you present that? Yeah. Just 1 minute. Let me get one of my team members to present the thing. So I think something, in my computer is causing that.
So my full screen is visible, sir?
Not yet. Yeah.
Yeah?
Yeah.
Okay. So stop me where I have to stop. So I'll just move the slides now.
Yeah. Yeah, keep going. One more. Yeah, one more. Yeah.
Yes, sir. Yeah.
Okay. So go back to that slide. So just to get the continuity, I think I was talking about the dual burden of HAIs, which is both impact the suffering the patient undergoes and also the economic burden of this particular condition. Next slide, please. See, the other important factor that actually puts sort of googly into this situation is the antimicrobial resistance. So India is the as epicenter of the global AMR crisis, and this is something which we are not proud about. We are first in the world in antimicrobial resistance, and this why we are talking about it here is when healthcare associated infection occurs, it leads to increased antibiotic use, and this drives the antimicrobial resistance, and that makes the HAIs harder to treat. So we give more and more higher antibiotics, and we are caught in this vicious cycle of increasing HAI and increasing antimicrobial resistance. So that is causing this problem even more complex than just the problem of HAI alone. Next slide. So the answer to the healthcare associated infection problem is the bundles, bundle care and infection control bundles. And that's the reason we chose this topic as the first webinar in the series. So the bundles are I think very important to understand these infection control care bundles, where they come from. So these bundles are a set of practices which are based on the current evidence and knowledge. So usually this evidence and knowledge is done by centers of excellence. They're published in journals and they sit there, either in the library cupboards or in the books. The practice doesn't usually change. But this is where the infection care bundles are bridging this gap. So this scientific evidence has been distilled into just 3 to 5 practices. And if you do that consistently, then the HAI will come down. Okay, so this is why the infection control bundles are so important. Next slide. So let us understand what are infection control bundles. It is not just a checklist. As I told you, this is 3 to 5 essential steps. And the power, very important to understand. This is one point I want you to take away today, that the power is in the synergistic effect. What do you mean by synergy? 1 plus 1 is not equal to 2. It is equal to infinity. So when you add these 5 steps together, it is not just 5. It increases the effect on reducing the HAI many fold. So that is why it is very, very important to understand that that is why it is called a bundle. It is not a set of practices. So we need to practice everything together. Next slide, please. And why are these bundles there? Is, as I already told you, it is proven by scientific evidence. So this is not just random steps somebody thought about, or some drug company brought a group of experts and took them to Switzerland and they thought about this. No. These are based on years of research and they are scientifically proven infection control measures, and when performed consistently and together will reduce the healthcare associated infections. And this is backed by our own NABH, WHO, ICMR, and of course the CDC. Okay, so this is based on solid scientific evidence. Next slide. And how do we measure these infection control bundles? As I told you, they work when they are performed together. So for you to be successful, you need to consistently implement all those components of the bundle, and there has to be 100% compliance. We either did a full bundle or not. It's not like any halfway. Even if you implemented 2 out of the 5, it's still a failure, right? So this is the mindset we have to change. People will say, yeah, we are following bundles. And if you really go through the audit and find out that they will be actually focusing only on 2 or 3, not on all the components of the bundle. So this mindset that if you say that I am doing bundle care, you need to be making sure that all these steps in the bundle are followed to the fully and 100%. Next slide, please. So this is what I was emphasizing, and then I put an extra slide just to emphasize this. It's an all or nothing principle. Partial compliance breaks the chain of safety. If you are just doing partly compliance, just a few of the components of the bundle, it still breaks the chain of safety. And even if you achieve 90%, it is still not success. You got to implement all the all the components of the bundle. Next slide. So these are the 4 core bundles. I think nothing new. It is targeting the 4 important HAI, the central line associated bloodstream infection, catheter associated urinary tract infection, ventilated associated pneumonia or events, and the surgical site infections. Next slide. So I'm quickly going to give you an overview of the components of the bundle. But before getting into that, I want to highlight the study by Peter Pronovost in the University of Michigan. He did something which is very, very simple. He again took these 5 steps in the CLABSI bundle and made sure that they were implemented in his ICU first. And what he did is he made sure that this checklist was given to the nurses. And the nurses had to supervise the doctors who were not supervised, at least check the boxes in the checklist. when they were putting the lines. So there was a lot of resistance, because there's always this hierarchy, and why are nurses, doing this? But he pushed on, and he was able to reduce the CLABSI rate to almost zero, which was 0.7%. So when he published this, people said, yeah, there's something, an anomaly which you probably could do in your own hospital, and no, it's not possible in other hospitals. Then he took a group of 18 hospitals in his area. So it is known as the Michigan Keystone Study, and did the same practice where he trained the doctors and the nurses on the 5 steps, and then put these thing into practice. And 18 months, all the 18 hospitals also brought it down to zero. And now it is being propagated all over the world now. And everywhere you talk about CLABSI, you cannot talk about CLABSI reduction without quoting Peter Pronovo's study. So this is a landmark study which proved that actually we were able to bring the HII rates to zero by using very, very simple set of practices. You'll see that it is not high-tech. It is so simple that you cannot say it is only possible in tertiary hospital. No, every hospital can practice these 5 principles of, the 5 components of the bundle. Next slide, please. So Peter Pronovos shifted the focus to patient safety, 5 simple actionable steps, and he enabled nurses to become IPC champions because they were not checking whether these 5 steps were followed every time a central line was put in their ICU. Next slide. So let me just look at these 5 steps. Hand hygiene. Hand hygiene means it is not just putting hand rub into your hand. This is a proper surgical hand scrub. You got to scrub up to the elbow, just like as if you are doing the surgery. And the second is maximal barrier precautions. Again, no putting a central hole around the CLABSI. You do a draping from head to toe as if you are doing surgery. So if you look at the ANTT principles, you have the sterile and clean procedure. So though CLABSI is actually a sterile procedure because you are putting a needle into the central blood vein, it is a sterile procedure, but it is done at the bedside. So many people use the clean principles of ANTT while doing CLABSI, just putting a center hole towel, just doing a hand rub. But he insisted that we do it just like a sterile procedure by doing a hand scrub, surgical hand scrub up to the elbow, and doing maximal precautions, draping the patient from head to toe, cleaning the skin with chlorhexidine, and choosing the neck over the groin. The femoral lines were discouraged, and daily necessity, that is this central line daily needed, was a question raised in everyday daily rounds, and if it is not, they were removed. Now tell me if any of these steps cannot be practiced in even the smallest of the hospital. These are such simple steps, and that is why these bundles really work. Okay, so that's about the CLABSI care bundle. Next slide. So remember, femoral site is higher risk. Every day the line stays, the risk rises. The quoted rate is 2.5% increase in HAI for every day longer the line stays in place. Next slide. Now we look into CAUTI. Here also there are very simple steps. Avoid unnecessary catheterization. So have clear indications and put the urinary catheter only when it is indicated. Aseptic insertion, the same principle. It is a sterile procedure. You are putting an urine tube into the urethra, into a sterile bladder. So it needs to be treated like a surgical procedure. So the same surgical hand scrub, wearing gown just as if you would go into surgery, and then doing, having a closed drainage. At no point in time, this closed drainage system should be interrupted. Unobstructed flow, very important. Every day during the rounds, during every shift, the nurse checks to make sure that the drainage tube is not kinked and there is unobstructed flow. And again, daily review to make sure that catheter, whether it is really needed. Again, simple steps, but when done together, reduces CAUTI. Next slide. Okay, so remember, 20% of catheters are placed without indication. So you really need to be careful. And we need to empower nurses also to question whether these catheters are required. Next slide. Now, coming into ventilator-associated pneumonia, head and elevation, as much as possible, try to give vacation to the sedation. Now, it sounds like a rhyme, but basically, you try not to sedate the patient too much, keeping them, some interruptions in between so that they are not too drowsy. And oral chlorhexidine mouthwash, and then DVT and prophylaxis. Next slide. Now, is a combined responsibility of nurses, respiratory therapists, and doctors. So it is a teamwork. Next slide. Finally, my specialty, surgical site infection. Again, simple steps. Prophylactic antibiotics wherever it is indicated. 60 minutes before incision. Don't use razors. Use clippers. Do the skin preparation as close to the surgical time as possible. Don't do it the previous night. Maintain normothermia during the surgery. Ensure glucose control during the surgery. So again, very simple steps, and this will decrease the HIR rates. Next slide. So shaving increases infection risk. So all the males or anybody who's all the people who use razors on the skin will realize when you put the aftershave lotion, it burns. That's because we have micro abrasions. The same thing happens, and if you do it the previous night, the next day morning, the skin is a good culture medium of all the organizations when you put the incision. So avoid doing that. Only do it closer to the surgery. Next slide. Now, the how of a bundle is team effort. Successful implementation is a multidisciplinary effort, and nurses are the forefront of this execution. That is why we have a nurse leader like Mr. Vinod talking about it today. Next slide. So there are barriers to implementation: overcrowding, supply gaps, staff turnover, policy practice gap. So this is the infection control nurse who's very angry that the nurse did not do the bundle care. But this is the reality, and you can we have sort of put the mind voice of that poor junior nurse here. I know it is wrong to skip the steps, but I'm caring for 12 patients with just one helper, right? So basically, we have problems. So it is nice for me to say, oh, this is very simple, no, we can do it. But at the bedside, there are so much of problems. And that's the reason we have Mr. Vinod here, who will talk about the actual problems and what are the challenges when in their hospital, they implemented these bundles. So that's the most important thing which we are going to learn today. Next slide. So these are the pillars of success. Leadership is very important. Multidisciplinary HIC team, continuous training, audit and feedback, empowering nurses, and adapting to local needs. Very, very important. Don't just borrow from another hospital. Every hospital is different. So we may hear from Mr. Vinod's experience, but when we take it, we need to adapt it to our own local culture. Next slide. So nursing leadership is the front line. We all know that the infection control nurse is the captain, but he or she has to look after 250 beds. It's not possible, and that's where the link nurses come in to decentralize the ownership. They have the ownership at the ward level, and that's how success can be promoted. Next slide. So friends, points to remember: HAIs are common, and deadly and preventable. Very, very important. Remember that. Bundles should be 100% reliable. If not, it's not actually successful. And nurse leadership is the critical driver, and the implementation depends upon the culture, the systems you put in, and how you adapt to the local milieu. Next slide. So one misstep can cost a life, but one empowered nurse can save it. So I think, Stella, I now invite you to introduce the speaker and then Mr. Vinod will take over this session. Thank you so much.
Thank you, sir. Thank you so much for your great insights towards the CAD bundle maintenance and especially about the pillar of success. So now it is the time to invite our speaker, Mr. Vinod Krishnan Koti, Group Director Nursing from Medanta Medicity. And he is a certified professional with a rich blend of qualification including BSc Nursing, MHA, MBA, HM, CPHQ and NABH Assessor. He brings with him a wealth of experience from his role as Head Quality at Deepam Hospitals, Chennai. Mr. Vinod has an exceptional track record in driving hospital accreditation and quality improvement initiatives. His expertise encompasses healthcare quality management, hospital operations, training and internal auditing. He also played a pivotal role in implementing clinical governance frameworks and patient safety strategies. With his deep understanding of national and international healthcare standards and his passion for building a culture of safety and excellence, we are sure his insights will be immensely valuable to all of us here today. Welcome you, sir, and over to you.
Thank you, Stella. See the slides.
Yeah, you just need to go on presentation mode.
Yeah, is it okay?
Yes, thank you.
Yes.
Yeah, good afternoon, all of you. And I wish to thank 𝐏𝐿𝐾, SkillMed, and Dr. Pari for this opportunity. I think I'll just log out from one of my devices because I had two devices. Okay. So to start with, I second what Dr. Pari said.
You have to switch on the camera in this device.
No, the camera is not functioning, and so that's why I had to log out from the other device.
Oh, okay.
Because there was an echo also coming for me. Okay, so I second, what Dr. Pari said, because the bundle care is the most simplest thing, to be practiced in a government, private, nursing home or anywhere, in the entire country, where we can practice. But basically, this is something that which each one of us should understand as nurses, doctors, healthcare workers, to ensure that our patients, go safe. And these are simple practices which can save a life or even cost a life if we don't do it. So to start with, the context in the Indian hospitals, if you see the HAI rates in Indian hospitals, the first thing is the Indian hospitals, the data is very, very poor in the hospitals. Wherever data which is available, you see that the HAI rates in India is somewhere close to around 6 to 7% across the country, wherever the data is available. So when you see the sepsis rate, it is almost 11.3 million. Like the sepsis cases in India alone were estimated to 11.3 million with 2.9 million deaths. That is 297. That is close to around 300 deaths per 1 lakh population in 2017, according to the data available. Then if you see the HIIs, as Dr. Pari was saying, that the forefront of HIIs are in the intensive care units. So you see there are 9.06 HIIs per 1,000 intensive care days, because these patients are more vulnerable and prone for HIIs. And the HIIs surveillance also, we don't have a common network across our country to monitor this or evaluate or even do a surveillance system, across. So government is moving in that direction to get a central repository to get all these things and then ensure that the surveillance mechanism exists. So as care bundle, concept, Dr. Pari very well explained that what is a bundle. So bundle is nothing but there are 4 or 5 activities you put together, and then, I mean, you create a checklist so that you don't forget to do things. So as nurses, I mean, when you go start working on ground, I mean, there are, as Dr. Pari was saying, that if there are 5 elements, I mean, in a bundle, if you even miss even a single bundle, like the most simplest, I mean, thing, then, I mean, it is not effective. So you have to practice yes or no. So there's nothing called as partial. So it is either yes or a no. So bundle is basically 3 or 4 activities put together, and then you start practicing. And this basically is a multidisciplinary approach. Like, for example, I mean, the WAP bundle requires a respiratory therapist also to get involved, I mean, in the bundle care to be performed. So this, along with, I mean, a team-based approach will definitely ensure that the patients, I mean, go safe from our hospitals. So let's see what are some of the best practices and guidelines. I mean, the first thing is on central line associated bloodstream infection. So central lines are commonly used in intensive care units and even in the non-ICU population, like the dialysis units or a intraoperative unit, oncology patients where you have a PICC line. So these are some of the patients who will have a central line. Now, whenever, I mean, we have any kind of line, a central line or a catheter, there are 2 things, I mean, which you actually monitor as part of a bundle care. One is the insertion, I mean, protocol or guideline, what is being followed, and the maintenance of it. So insertion is basically, I mean, this is more towards, I mean, where a doctor inserts a catheter or inserts a line, I mean, where the complete aseptic techniques are followed. So basically maximum sterile, as Dr. Pari covered it, I mean, you should be having a surgical mask, surgical gloves, wear a complete gown, drape the patient completely, and you're doing a complete sterile procedure when you insert a central line for a patient. So it's not that, I mean, you do a hand wrap, pick up a gloves, wear it, and then start doing a insertion. So because this also can create infection, I mean, for patients. So the next level is basically to ensure how do you maintain this line. So this also, like maximum sterile barrier precaution while maintaining the hand hygiene, the simple and most important technique to practice hand hygiene. Then disinfect the catheter hub whenever you use it, and close the catheter hub always when it is not in use. Use a dressing site material, I mean, which are approved and authorized in your own hospital, and where you find that these dressings are not touched with bare hands unless it is a emergency situation. Even in emergency situations, see that, I mean, you don't create infection, I mean, for patients. And the most important thing is to ensure that daily review whether the catheter is required in situ or not. So this review is the most important thing. I mean, if you consider 3 or 4 activities, I mean, during the bundle, this is something which is most important. I mean, talk with the doctor, discuss with the infection control nurse, and ensure that is it required really, or is it supposed to be removed. So some of the benchmark, I mean, if you see the CDC benchmark, if you see, there are 2.6 HAI, the CLABSI, I mean, out of 1,000 central lines, I mean, and the NHSN benchmark of 95th percentile is, this is the benchmark of 2020, I mean, according to CDC. And INAC, I mean, if you come to India, the INAC, I mean, shows 5.1. I mean, you can see 2.6 to 5.1, I mean, in India, wherever the data is available. This is only according to the data which is available. And in the Indian rate, if you see, I mean, it is close to around 8 to 12 per 1,000 central line days. The next thing is catheter-associated urinary tract infection. Again, the same thing goes on. How do you do an insertion technique and how do you do a maintenance bundle? So the most common HI, I mean, you see in a hospital is catheter-associated urinary tract infection. This definitely increases the cost. This definitely increases the hospital stay for the patient, and obviously the morbidity also. Now, in the insertion bundle, what are the simple things, I mean, which you need to maintain? The maximum sterile or barrier technique, I mean, when you insert, I mean, the catheter, competencies, I mean, documented competencies. Basically, I mean, the person who's trying to insert the catheter has to be competent enough to ensure, maintain a complete asepsis while you do the procedure. And then there is an unobstructed flow for the urine. I mean, there is no kink, the bag is not, I mean, above the waist level. So these are some of those things that which has to be maintained. Then when you come to the maintenance bundle, the most important thing, again, hand hygiene, daily assessment of the catheter similar to the CVP line or a central line. I mean, look at, I mean, whether the catheter is required for the patient or not. If it is not required, please remove it as early as possible. Then a timely catheter care, and then the drainage bag, always ensure that it is below the waist level. Now, if you see the benchmark, the CDC, I mean, shows almost 2 per 1,000 catheter days. This is again, 2020 data. INEC data shows, it is 2.1 per catheter days. The Indian rate is close to around 2.5 to 4.5 per 1,000 catheter days. The next, in the line is basically ventilator-associated pneumonia. Now, maybe ventilator-associated pneumonia is something, at a end stage, you find that the patient has already got infected. There is one more, many of the hospitals have started a monitoring, nowadays, which is called as ventilator-associated events, or VAE. This is basically a precursor where, the patients, before they get into the ventilator-associated pneumonia, you can start tracking VAE, ventilator-associated events, and then you can even prevent, the patients ending up in the VAP. So that is also a good practice, which many of the hospitals have started practicing and monitoring, the VAE also. So again, for this, hand hygiene, prior and after the procedure, head and elevation, as far as possible, if there are no contraindication, you maintain at least from 30 to 45 degree. Timely oral care is one of the most important, for patients, with VAP. Initiation of safe parenteral nutrition, then sedation vacation. Sedation vacation is basically you try and avoid sedation for patients as far as possible, unless it is a complete requirement for patients. Then DVT prophylaxis is another most important thing, where patients, because these patients are lying for a long while with no movement. So DVT prophylaxis is one of the most important thing, where you ensure that the patients do not end up in embolisms. Then weaning protocol. You plan the weaning protocol and start, testing on patients, and then do those weanings as per the plan. Now, VAP occurs almost in 20% of patients who receive mechanical ventilation. This is again some data which shows, and definitely it's a huge financial burden for patients. And when you see the mortality rate, for patients who get VAP, it is almost 20 to 50% of the total deaths, which happens and with VAP. Then VAP also is preventable when we start practicing, the bundle care, for patients. Again, the benchmark VAP is basically the CDC. You see, 2.1 per 1,000 ventilator days, which is again a 2018 data. The INEC data shows, which is very high, is 9.4 per 1,000 ventilator days, and the Indian data is almost 6.4 per 1,000 ventilator days. And maybe the next slide, the surgical site infection, I think the slides are missing here. Maybe I'll just discuss the surgical site infection as Dr. Parikh was saying. Surgical site infection, the most common thing which we find in India is that among the HAIs, the most neglected part would be the surgical site infection, because surgical site infection, you see that you track the patients for almost a month, and where patients, who got an implant device, you almost, track the patients for almost 3 months and 90 days, which is humanly not possible. Even in a private hospital, tracking these patients are very, very difficult. And when you consider bundle for these patients, yes, the simplest thing is do not use shavers, use clippers, for this patient. Use a CHG, based rub to scrub the patient, maybe the evening before the surgery and the morning of the surgery, which is again a good practice, where you will ensure that the prevention of surgical site infection happens, through these techniques. Then 60 minutes before the incision, giving a prophylactic antibiotic according to the hospital policy, what you have. And then maintaining a sterile environment, for dressing, and then cleaning of these patients, post-procedure. So these are some of the simplest technique where if you practice, you can prevent, surgical site infection. Now, what are the challenges you face in practicing this bundle care, in the hospitals, and ensuring the patients do not get, HI? Resource constraint. Basically, these resource constraint can be, through can be the staff, nurses. Basically, you don't maintain a normal R and accepted a nurse-patient ratio. So obviously, this could be a challenge, for patient care. There are no obvious equipment which are resource constrained, not available. Like when you say equipment or material, like hand wraps are not available, or alcohol swabs are not available. So these are some of those challenges which you will find that, it is very, very difficult for you to practice. And when you see, a patient with MDR, you don't have isolation facility to move this patient and ensure that, you practice isolation facilities for these patients. The second thing is, if you go to a private hospital, you still consider, it to be a maintaining, quality in private hospitals. But when you look at the public hospitals because of the overburdened, patients in the hospital and the lack of healthcare manpower, in the hospitals. So practicing this and ensuring, these are a big challenge. Again, I said, the nurse-patient ratios, then staff. Now, doctors and nurses in India, if you see, the private hospitals, if you see the nurses attrition, ranges between 50 to 80%. Doctors attrition at a junior level ranges between 80 to 100% also in some of the private hospitals. So this is becoming a huge challenge, for us in our country, especially in the private hospitals where people demand, service, and then you are supposed to maintain, that quality. And when there is a high turnover, training the staff, and then the staff coming, to that level of handling, patients is a big challenge. Then inconsistent surveillance systems, again, there's no manpower, our people, do not do surveillance, exactly as per the expected policies and protocols of the organization. This is again a challenge. And the last but not the least, overuse of antibiotics. You see, in our country, even antibiotics are even sold, over the counter. So this is again a big challenge, because we are entering into the antibiotic, resistance, which is a big problem in our country also, because you see that patients, end up taking, antibiotics with a 3 or 4 and even in 5, in some instances, which is a huge challenge, where to ensure that the antibiotic stewardship program is a challenge, in every hospital. So again, the high patient load, limited trained staff. Now, what are the impacts of these things? This is basically the impact is difficult to monitor and ensure the compliance. Then there are inadequate supplies for asepsis. You don't have a sterile gown or a gloves. For practicing, the aseptic techniques. And then data collection is also a big challenge. Because when you don't have less of manpower, the data collection is also, and the way we collect the data is also a big, challenge, because each one of them, if they don't follow the protocol of data collection, then, it is basically an individual's subjectivity which comes into the data. Now, this is an interesting study which I found, where it was done in 26 tertiary hospitals in India. And if you see the findings of this, 26 hospitals. So they found that 262 healthcare associated bloodstream infections were found, in this when they started tracking, and 737 healthcare associated UTI was a common, thing from the 89 intensive care units. And this is between 1.5 year data. So if you see, central line associated bloodstream infection rates were the highest in neonatal ICU, which is almost greater than 20 per 1,000 central line days. Then catheter associated urinary tract infection were the highest in the pediatric medical ICU, which was almost 4 to 5 per 1,000 urinary catheter days. So this actually shows that the kind of prevalence of healthcare associated infections in our country in the hospitals, both in private and in the public hospitals. Obviously, private hospitals try to maintain things in a better way, because of the availability of resources, because of the availability of infrastructure, because of the availability of manpower and all those things. Now, what is the role of a nurse, in our nurse-led, models in ensuring that we reduce our HIA and implement the care bundles? As Dr. Pari was saying, see, this basically infection control in a hospital can only go through from a top-down approach. The leadership has to be taking the responsibility and ensuring that infection control, our patient safety is the prime or paramount importance, which flows from the leadership. And you actually, when the leadership is committed to this, you will also create a policy which is ensuring that, these things are on ground and there is no way of going away from it. So then, once, you create a policy, then the staff training and education is the second thing, which is most important, for people. As I said, that the attrition level, in our country, in a private hospital is huge. So if you don't have a robust, training, education and training, in the hospital setup, it is very, very difficult to ensure that these kind of care components are practiced in the hospital, and then standardize the care. So this is also, you find, in many of the hospitals, I mean, where the practices are not standardized. Like, I mean, if you enter into the ICU, the medical ICU might have a slightly different practice, surgical ICU might have a different practice. So if we can avoid this and have a standard care across the hospital, so it is easy for the healthcare workers also to ensure that, because even, I mean, because of the shortages, I mean, people from one area to the other area, when they still go and start working in the other ICUs, I mean, it should not be a challenge because you have a standardized care across the hospital. Now, what are the key components for successful implementation? One, I told you, education and training. There has to be a robust mechanism of training, I mean, for these things. And these trainings have to be ongoing and consistent. I mean, there has to be refresher trainings, I mean, as per the requirement, not restricting that, okay, we'll do once in 6 months or once in 3 months. It is basically need-based. Then there has to be clear guidelines and protocols. I mean, this is something that, I mean, the leadership has to ensure that the guidelines are very clear and the protocols are ensured that, I mean, the protocols do not have any ambiguity, I mean, in creation. Then regular feedback and data collection. Basically, I mean, you see the infection control nurses collect the data for the hand hygiene compliance or, I mean, the environmental surveillance. So these are some of those things that once they collect, I mean, there is a regular feedback to the team also that, okay, I mean, your compliance on these things were this, I mean, for this month, and these are the actions, I mean, to be done, I mean, to improve, I mean, in the next month. So these are some very, very important thing, I mean, for the team who's working. Then leadership and support, I mean, as I said. Then, I mean, you have a data, I mean, which has to be evaluated, and there has to be a continuous data-driven decision making, I mean, which has to take place in the organization. Now, how do you sustain this change? Basically, creating a culture in the hospital for patient safety and ensuring that, I mean, the thrust is on infection control, because infection is something that, I mean, which can save a life or also lose a life, I mean, this thing. Then definitely capacity building because of the attrition, what I told you, and then a collaborative, I mean, and a benchmark, I mean, what you create for your hospital, and then chasing, I mean, those targets, I mean, which you set for the organization. So in summary, implementing evidence-based infection control bundles can significantly reduce the healthcare associated infections and improve the outcomes. Now, to ensure success in our hospitals, like we have customized bundles to our local context while adhering to global best practice. This is also something which Dr. Pari said. Please do not pick up, I mean, like, for example, you have a very sophisticated private hospital which has got a great practice. No, don't try to pick that practice and then try to implement in a smaller hospital where it is not feasible. So see what is best, I mean, for in your local context, and then pick up that practice and ensure, because it does not depend that, I mean, a hi-fi practice can change, I mean, infection rates. Simplest, because all the 5 activities, what Dr. Pari was saying, that can reduce the HAI. So identify what is locally, I mean, available for you, what can be practiced, and then ensure that that is being picked up and then practiced. And then train and empower the frontline health workers. Very, very important. I mean, a nurse should be able to question a doctor, I mean, or a physiotherapist or a peer nurse, I mean, if she's touching a patient without doing a hand hygiene. So this is very much required for the frontline workers. If you don't empower them, I mean, then having infection control standards, protocol, policies, guidelines, it's a waste. I mean, if you don't empower the frontline workers, then definitely leadership commitment is very, very important to ensure that the patient safety in the hospital is maintained. And then monitor compliance regularly and the outcomes also, and have a data-driven improvements, I mean, rather than having a very subjective on this. Then create a culture of accountability and safety with every single member in the hospitals. And when we do all these things, definitely we can bring down, I mean, the infections in our hospitals. And I mean, throughout, when we start practicing across the country, we can also ensure that the country also move towards the next level where we try and prevent infections also. Thank you.
Thank you so much, sir. Thank you.